y a nombre del Departamento de Evidencia e Inteligencia para la Acción en Salud de la Organización Panamericana de la Salud y la Organización Mundial de la Salud, les damos la más cordial bienvenida a este seminario virtual titulado Estimaciones de exceso de mortalidad de COVID-19. Es importante resaltar que este evento está siendo organizado conjuntamente por el Departamento de Datos y Análisis de la Organización Mundial de la Salud y por el Departamento de Evidencia e Inteligencia para la Acción en Salud de la OPS. Agradecemos de sobremanera su registro, su interés, su participación y, como siempre, todo el apoyo que nos dan en los procesos de consulta de estimaciones. Un aviso importante relacionado con características de este seminario: se cuenta con servicio de interpretación español-inglés. Ustedes pueden elegir el idioma de su conveniencia, identificando el logo en la parte inferior del lado derecho de la pantalla. Es un mundo. Ustedes seleccionan interpretación y ahí les va a aparecer inglés y español para que los seleccionen. Los invitamos también para que incluyan sus preguntas y comentarios en la sección más o menos cerca al centro, al lado del chat, que es de Q y A. Por favor, incluyan todo lo que consideren importante y aparte tendremos una sesión específica de preguntas y respuestas. Y sin más, a continuación tengo el placer de invitar al doctor Sebastián García Saizó, director del Departamento de Evidencia e Inteligencia. Adelante, doctor.
Muchas gracias, Patricia. Y aprovechando que tenemos el servicio de interpretación simultánea y en vistas de que la mayor parte de este seminario se conducirá en inglés, me permito hablar en español en este momento. Quiero dar la bienvenida a todas y a todos a este seminario destinado a entablar un diálogo, una discusión sobre el exceso de mortalidad y las metodologías asociadas. Agradezco a nuestros colegas de la sede en Ginebra, de la Organización Mundial de la Salud, por el apoyo y, por supuesto, por toda la coordinación que ha existido para realizar este importante ejercicio y, por supuesto, también la realización de este seminario puntual. Y a todos ustedes que nos acompañan hoy con la representación de sus países para participar de este ejercicio global y, por supuesto, para resaltar la importancia que esto tiene para la región de las Américas. Agradezco también a todos nuestros colegas de la Organización Panamericana de la Salud que se conectan desde las oficinas sede de los países y que han apoyado también este ejercicio y que continúan apoyando su desarrollo hacia adelante. Permítanme dar unas palabras sobre un poco el contexto de esta reunión que hoy nos convoca y la relevancia que tienen en todo lo que ha implicado una respuesta de más de 20 meses a la pandemia por COVID-19 y lo que implica realmente este ejercicio de cálculo, de análisis sobre el exceso a la mortalidad. A medida que la pandemia de COVID-19 ha seguido desarrollándose, es decir, es algo que todavía no se supera, no en nuestra región y, por supuesto, no en ninguna otra parte del mundo. La OMS, la Organización Mundial de la Salud, ha estimado al menos 3 millones de muertes en exceso solo para el año 2020. Esto representa alrededor de 1.2 millones de muertes más, 1.2 millones de muertes adicionales sobre los 1,8 millones de muertes por COVID-19 que se han reportado en 2020 por países y territorios. Sobre la base de las estimaciones de exceso de mortalidad por COVID-19, los 4,8 millones de muertes mundiales que se han notificado a la OMS hasta finales de septiembre de 2021 implican probablemente un subregistro muy importante de lo ocurrido, con cifras reales que se estiman al menos 2 a 3 veces más altas de esa cifra. En este sentido, el exceso de mortalidad se utiliza como una medida para comprender con mayor certeza el impacto directo e indirecto de los fenómenos. En este caso, la pandemia de COVID-19. Y con esto entonces hablamos de las muertes debidas a COVID-19 que se certifican correctamente, junto con aquellas que se atribuyen incorrectamente a otras causas, así como el efecto neto de los cambios en otras causas que están relacionadas con la pandemia, es decir, todo lo que ocurre en torno, por ejemplo, a la prestación de servicios de salud, que en un momento dado pueden también repercusiones en otras causas de muerte. A lo largo de la pandemia, a lo largo de estos ya más de 20 o 21 meses, hemos visto diversos desarrollos de análisis de exceso de mortalidad de diversas fuentes y utilizando diversas metodologías. Es en este sentido que la Organización Mundial de la Salud y el Departamento de Economía y Asuntos Sociales de las Naciones Unidas convocaron conjuntamente a un grupo técnico asesor específicamente enfocado en la evaluación de la mortalidad por COVID-19 y que busca como grupo técnico desarrollar métodos armonizados para estimar el exceso de mortalidad desde enero del 2020 y hasta junio del 2021 como una primera etapa. Como parte de este importante trabajo que se ha desarrollado hasta la fecha, el grupo técnico asesor ha identificado fuentes de datos clave para complementar la información disponible que ya se tenía en la Organización Mundial de la Salud. Y también se han formulado modelos estadísticos alternativos para abordar las lagunas, tanto en los datos necesarios para estimar las muertes esperadas, como en las muertes reales. De igual forma, se están llevando a cabo consultas con los Estados miembros en todas las regiones para solicitar el apoyo de los países en 3 puntos clave. Por un lado, examinar las estimaciones preliminares, poder realmente revisarlas, entenderlas y por supuesto también comparar y revisar desde la perspectiva nacional, proporcionar información sobre los datos y métodos utilizados, posterior a este análisis, a esta revisión, y también proporcionar datos adicionales, cuando estén disponibles, que pueden no haber estado disponibles previamente y que pueden ser significativos para complementar o mejorar el análisis. Este seminario que hoy nos convoca, esperamos que sea una oportunidad para nuestra región en esta consolidación del importante ejercicio global que se ha llevado a cabo en torno a este análisis del exceso de mortalidad y que podamos así también contribuir a fortalecer la respuesta a la pandemia y por supuesto también conjuntamente construir el camino hacia el futuro en el fortalecimiento de nuestros sistemas de salud, de su capacidad de respuesta ante retos futuros y por supuesto también tener una visión más clara del reto que hemos enfrentado. Agradezco nuevamente la coordinación permanente que ha existido para este ejercicio a nuestros colegas de la sede en Ginebra, de la Organización Mundial de la Salud. Por supuesto, agradezco también a todos en el Departamento de Evidencia e Inteligencia para la Acción en Salud por la coordinación que ha implicado la realización de este importante esfuerzo de análisis y también la coordinación de este seminario, y a todos ustedes que forman parte del grupo desde los países con los que estamos trabajando y con los que estamos construyendo justamente esta capacidad para establecer un análisis más robusto. Sin más, yo agradezco a todos, les deseo éxito en este seminario, por supuesto estaré disponible para la discusión y deseo que podamos construir esto en conjunto. Muchas gracias y Patricia, te regreso el micrófono.
Muchas gracias, doctor García. De acuerdo a la agenda tenemos las palabras del doctor Stephen McFeely, el director del Departamento de Datos y Análisis de la Organización Mundial de Salud, que sabemos que pronto se va a conectar con nosotros. Entonces, en ese sentido y para seguir con la agenda, invitaría a nuestra colega Diana Esteves para que nos hable más sobre el proceso de consulta. Muchas gracias, Diana.
Gracias, muy buenas tardes con todos. Pedimos a nuestra colega, thank you so much, Saki. Voy a comenzar a hacer la presentación ahora en inglés y las personas que que desean seguir escuchando en español pueden revisar en la interpretación y cambiar al idioma inglés, por favor. So good afternoon to everyone, good morning. We are going to talk about the country consultation process for the estimates of excess mortality. This process has been launched in October 2021 because we wanted to engage member states and request feedback on the methods and estimates that were produced on COVID excess mortality. The country consultation process was launched through the country portal, which is part of the new WHO World Health Data Hub. So you must have received the circular letter that was shared through the official list of addresses in headquarters through the Director General's assumptions. And the consultation was started on the 4th of August when the circular letter was shared. This is the first round of the consultation and it has already closed in 8th November. Next slide, please. Well, the online country consultation process, as you know, started in August with the circular letter. We received many focal points nominations from countries. We have worked in collaboration with the regional office and the country offices who have supported us providing feedback. Through the country portal with the nominated focal points. In this country portal, member states are called to review the data sources, review the methods, provide advice on primary data sources that may not have been previously reported or used in our database. Member states also share inputs or additional feedback as required, and there is interaction with WHO technical team to clarify any questions that may come. We are having this regional webinar with AMRO regional office and PAHO, and also we will have some regional webinars with other regions to clarify any questions that you might have, to have clarity on the methods as well. Then we are going to run again the estimates with the provided feedback that we will receive from you, and as well as new data that has been shared through the country consultation. And we will have the release of these preliminary estimates by the 17th of December. As you know, this is a work in progress, and we're going to continue receiving inputs from countries. And we will have a second release after reviewing the feedback that we have received after the 8th of November. So for a second round of excess mortality estimates. Thank you very much.
Muchas gracias, Diana. Solicitamos, por favor, a los panelistas verificar su micrófono porque nos acompañó lamentablemente un sonido de fondo un poco desagradable. Agradecemos su comprensión al respecto. Y ahora, siguiendo la agenda, vamos a pasar a la presentación sobre el portal de consulta con los países, a cargo también de una colega del Departamento de Datos y Análisis, Roxanne Moore. Gracias. Adelante.
Thank you, Patricia. As Roxanne is on leave today, but she has prepared a demo video to present the country portal, which is the online platform that the country consultation is taking place. So I am going to share the video right now.
Hello, I'll be providing a demo today of the country portal, and in particular the COVID-19 excess mortality estimates consultation that's currently active. To give a better understanding, we'll be going through two perspectives today. One, which is the perspective of a member state, and then another perspective of what does it look like for WHO focal points at the global level as well as regional level. WHO focal points at the country level also have access to the consultation. Their experience looks the same as member states. So to start off, once a member state logs into the country portal, they are redirected to their active consultations. On their landing page, they have an understanding of what is the consultation, any of the global focal points, as well as other member state focal points that are also engaged in their consultation. Additionally, they have a progress monitoring bar that gives a better understanding of where they are during that process. For this consultation, there are 3 stages. The first stage is the dissemination of methodology and preliminary estimates from WHO to the member state. The second stage enables the facilitation of feedback, either the sharing of data or conversation over chat. And the third is the onward dissemination of the final estimates. To look further into what that looks like, there is unified guidance in terms of what are the files being shared, as well as the display of files right next to it. Within the second stage, additionally, there is instructional guidance and requests for data. There is a template being shared with member states to facilitate feedback, and they have the ability to upload any files that they so desire, as well as provide commentary on those files themselves. What this looks like after they've uploaded files is that their files display here, and any upload notes that they have provided display over there. Once a member state is finished providing feedback, they can mark the stage as complete to indicate that they're done providing response. The files provide a unified file experience, so not only the files that they've shared, but any files that have been shared to them by WHO, and similarly a unified chat experience. So when I say unified chat, this means all persons within the country and all 3 levels of WHO. To go to the other perspective from WHO, if I am logged in, it's quite similar in terms of the overarching structure and design. There's additional materials to help facilitate the consultation, particularly how do I add and edit that text that we've seen throughout the member state consultation. How do I facilitate and add users to a consultation? How do I better understand at the country level any engagement or progress going on across the board? So you can further dig in and better understand that response. On the file side, quite similar to member states, this is a unified file design, but rather than one country, it's many countries. So you can better understand all files that are being shared and better see any notes that are being left and provided by member state focal points. And upload any materials. Similarly on chat, not only do we have one chat, but many chats from all the countries that are conversing with us to be able to better facilitate the consultation process. We also have a monitoring dashboard that is providing more analytics at the country level of who has been involved at what stage of the consultation. As mentioned, support and access for our WHO colleagues at all 3 levels. Your view does shift based upon your role. So for colleagues at the region, you have access to all focal points within your region. Global focal points have access across regions. WHO country offices have access to their country. And so thank you for this demo. The colleagues will be able to answer questions afterwards.
Thank you, Patricia, who I'll give the floor back to you.
Muchas gracias. Aquí también agradecemos a Roxanne por esa presentación sobre el portal. Recordamos nuevamente a todos los participantes que incluyan sus preguntas, comentarios, y hemos visto 2 sesiones muy importantes como son el proceso de consulta, sus distintas etapas y el portal que permite ese acercamiento y esa interacción activa entre los puntos focales y nuestros colegas del Departamento de Análisis y Datos de OMS. Y también consideren que como oficina regional nosotros apoyamos en todo este proceso para que la comunicación sea mucho más activa y pues podamos tener una discusión mucho más rica. A continuación voy a dar la palabra, esta es la presentación a cargo del doctor William Montgomery, también un colega del Departamento de Datos y Análisis de la Organización Mundial de la Salud. Adelante, doctor.
Okay, greetings to all participants. My name is William Musemburi. So here at HQ, I've been leading our analytical work on estimating the full impact of COVID-19 pandemic. So this has been looking at the global regional and country levels. So it's a pleasure for us to be able to share the progress we have made. And my hope for this webinar is that it will be informative for you, but also collaborative for us to learn from you and improve on the described processes. So my presentation will include a brief background in which I'll describe the gaps in the data that make it necessary for us to do this work. Next, I'll go into some of the statistical modeling that has been done to generate the various components of COVID impact, which we're quantifying with excess mortality. We will discuss how excess estimates have been broken down by age and sex. And finally, I'll reiterate some of the activities we're conducting. Closing off, we might have some time for discussion. So as of the 23rd of November, there are over 257 million confirmed COVID cases and over 5.2 million deaths that have been reported to WHO. So the reported deaths have been concentrated in 3 of the WHO regions, with almost half, that's 45%, being in the PAHO region, almost 29% in Europe, and 14% in Southeast Asia. So that's about 88% of all the reported deaths. Following on from the geographic groupings, the World Bank income group slice of the data indicates that about 82% of the reported COVID deaths are in upper middle income and in the high income economies. The problem is that the reported numbers do not give a complete picture of the impact of the pandemic. So in general, the reported numbers underestimate the lives that have been lost due to the pandemic. And this is because they miss those who died without testing. They're contingent on the country correctly defining COVID as the cause of death. And they miss the increases in other deaths that are related to the pandemic and overwhelmed health systems or patients avoiding care. There are places where responses to the pandemic have been protective with reduced contact and lower expected infectious disease, but such are isolated. So excess mortality is crucial for comprehensively quantifying the impact of the pandemic. We can define it quite simply as the additional number of deaths for a specified location and time period compared to the number expected. And this is for all causes. The excess measure encompasses deaths from all causes, those directly attributable to COVID-19, and those indirectly due to it, and also any changes in other causes. So this quantifies the impact on the whole system. However, estimating excess mortality is challenging because of data limitations. So globally, only a subset of countries have fully functioning civil registration vital statistics systems. Of the countries that do, there's an observed lag of more than a year before the WHO receives cause of death data from them. Sex and age structure are necessary when we quantify health impacts and standardize across countries. And these attributes are missing from many of the data that are available in the short term. For example, most of the reported COVID deaths do not have age and sex as identifiers. So we can talk about data availability. We sent out a call to country focal points to share all cause data for 2020 and now 2021. And after we conducted an audit of publicly available databases, we managed to obtain data for approximately 94 countries. To illustrate, the plot on the left maps the geographic distribution and quality of the data that we gathered when we began this process. And the table on the right aggregates these by WHO region. And we can see that we have almost full representation for Europe and more than half for the region of the Americas. However, very little data are available for the other regions, especially Africa region and Southeast Asia. So in response to the data gaps, the WHO and UNDESA, they convened a technical advisory group, or a TAG. So you can see on the slide, I shared the link for more detail. So the TAG has over 60 participants who are experts in biostatistics, epidemiology, demography. And broadly speaking, the expectation is for the TAG to appraise or to assess how excess mortality is being estimated by the WHO, and to help us to develop tools that can be used to estimate it where we have these huge data limitations. We have also hoped that the network of national statistical officers could be leveraged to help us get more data. And even with that, progress has been limited. So the set of methods that I'll be going into now have been developed with the support of the TAG. So as I mentioned previously, the two main components of excess mortality are the expected deaths and those that are observed. So for the countries with historical time series by week or month, the first thing we have done is to derive the expected deaths. And we've done this using an over-dispersed Poisson type of model. So we've used a negative binomial model. And this has parameters that are shown on this equation here, mu t and phi. So phi is an over-dispersion parameter. So this allows you to compare populations that have different variants. And then we have mu t being estimated, and this is our expected number, with the log linear model. So log mu t is alpha plus beta t plus gamma t. So in this equation, this is the equation we're using for the expected phi. Alpha is an intercept. Beta, in this case, is just tracking the annual trend. So if you're talking about expected deaths, you'll have how they've changed through the years. So we have that being tracked by beta, but we also have gamma, in this case of gamma t, a smooth function of time. And this gives us the seasonal variation. So we parameterized our expected deaths to account for annual changes and seasonal variation. And in this case, we've just fit this gamma t using a penalized cyclic cubic regression spline. So this is for the seasons. So what we can see in this plot, let me put a country from the region. So really we have, for the period in question, we look at the historical data, and we, using the negative binomial model, accounting for the annual trends or the annual changes, as well as the seasonal fluctuations, we're able to plot. So what we're trying to do really is, the blue in this plot, those are the reported deaths, and then the green, those are the expected deaths based on the model. And the goal is for us to be able to determine the expected, so this green trend in the period 2020 and 2021, because really what we want to get to is the expected and the reported to calculate the excess. And you can see, I mean, this is a good example where for Brazil, there's very close relationship between the sum of the expected and your COVID and what has been reported. And this is different, for example, if we put, say, Bolivia in there, where you can see if you compare the reported deaths to the sum of the expected and the COVID, there's a huge discrepancy there, which suggests, an undercount for the full impact of the pandemic. So something that's also not shown here are the expected deaths for places without time series. And for these, we've based the expected on numbers that came from the global health estimates. These are forecasted, again, using a random walk. And then we estimate monthly expected just by looking at the average by month and any fluctuations in the temperature. Now, this is the crux of the work we've been doing. And this, as I said previously, there are a number of countries that do not have data. And for these, we have to predict what is a plausible number for the all-cause estimate for the year 2020. So we looked at a number of models. Before we settled on this one, we looked at linear regression, we looked at machine learning, we've looked at Poisson models and negative binomial models. And the model I'm describing now is the one that the tag is more or less happy with. So looking at the equations, if we define our exposure or our population for some country C as NC, N with a subscript C, and if we let Y with subscript C and T represent the total reported deaths for some time T, we also have, in this case, E, which is the expected. So that is what you would have seen with the green line. To estimate all cause, we are fitting an over-dispersed Poisson model of the form. So we have Y, our predicted deaths are conditional on theta, and this follows a Poisson model with parameters E, theta. So E, that's your expected, and theta is a relative rate parameter. So if it's greater, this is a relative rate greater than 1. So what it basically tells you is how are you going to scale your expected deaths to get your predicted number for any particular time period. And as I said, we're using a over-dispersed Poisson model. So we model the log of the relative rate as a function of a number of components. So for one, we have the intercept, which is beta with the subscript 0. We have some covariates that change over time. So they're time varying covariates. And in this case, they're indicated by this capital letter B. And that is your reported COVID, your positivity rate, any measures that were implemented by the government to try and contain the pandemic. These are all sort of modeled as time varying covariates, and they have this capital letter B. And we assume that they're associated with our log theta via a smoothing, and we use a second order random walk on the time varying covariates. We also have a set of covariates that don't change over time. So these are time invariant covariates, and these are indicated by the capital letter G. In this case, we have things like income grouping, comorbidities, so things like your non-communicable diseases, and as I said, income grouping, high income, low income, and so on. So we fit all of these models using INLA. So this is a program for Bayesian analysis that more or less that is much faster than others. And we've used some penalized complexity priors in this assessment. So next I'm going to talk about, so we've talked about we had expected deaths. We fit a negative binomial model to get the expected deaths for places without data for 2020 and 2021, we looked at this over-dispersed Poisson with a relative rate model to be able to estimate and to get this estimate of excess, because we have it as the difference of those two. The third component then is being able to break up the excess mortality into age and sex, at least to be able to predict what are the age and sex differences in excess mortality across countries. So for most countries, the sex and age attributes are not in the data. And these are necessary when we start looking at how impact of COVID relative to other causes, life tables, the impact on life expectancy. So to generate the estimates of excess mortality by age and sex, we've looked at age disaggregated by 5-year age bands. So we're looking at groupings 0 to 4, 5 to 9, 10 to 14, up until the open interval age 85 and older. So what we are looking at really is the mortality rate between ages X and X plus N for time T. And in this case, we're just looking at year 2020. And we want to be able to estimate this for each, for both males and females. We only have data for 60 countries. So, and this is for 2020. So our goal then is from those 60 countries to determine a pattern for age and sex differentials, a standard pattern that we can then apply to the countries that don't have data. So for this first round, this is preliminary. We have used quite a simple algorithm. So firstly, for the countries with reported sex and age data, we calculate these log ratios. So you can see RSX, that's our ratio, is the log of NMSX. And this is your mortality rate for sex S, and the subscript on the O is for the observed and the E is for the expected. So for each, within each sex group, for each age group, we look at what is the ratio of the observed mortality rate for that age and sex with the expected. And this is specific for the countries with data. Secondly, we find a systematic way of grouping countries so that we can, based on underlying age patterns and experience and the excess mortality. So really what we want to do is we have a distribution of age and sex patterns in the countries with data, and then we want to be able to allocate those to the countries without. So we first of all need to group the countries without so that that allocation will be appropriate. So we need to find a systematic way of doing that. The third thing that we've done is then we make sure that each country of the 194 is in a cluster or a grouping so that it receives these log ratios, and then we apply them, okay? So in terms of the clusters themselves, we've considered how to do it, and right now, one way that you could group the clusters naturally would be geographically, right? Where we just say, you know, WHO region, every country in the same region receives the same age pattern. But this poses two dilemmas. First of all, not all regions are represented in the data. So there's no countries from Southeast Asia that have age and sex patterns, and there's only one country from Afro. So if we were to use the Afro country, the South Africa, which is data, to extrapolate to the region, that country would dominate the pattern. And then we see that even within close geographic proximity, so countries that are close to each other, the scale of the impact of the pandemic has been different. So even potentially by sex and age, it would vary. For example, Finland shares a border with Russia, but the reported case rates are different for the two. So we've used what's known as a k-means clustering. So this is just a method that's commonly used to group data into k groups that have similarities. So these similarities are being inferred by the data itself and are not being applied a priori. So there's many features that could be used to create the clusters. We consider 4 features in total. So we've looked at the mean age at death. So if you, in this case, X is our age, and capital letter DX, those are deaths to people aged X. That's our alpha D could be your mean age at death. Mean age of the population, again, very similar to your mean age at death, except this time your numerator and denominator are weighted by the population. We have the crude excess mortality rate. So this is your mortality, the excess mortality rate for the country divided by the total population. And then you have your excess mortality as a proportion of all-cause death. So using these 4 features, we've applied the k-means algorithm to cluster and to group the countries. So we're not grouping them just on regions or just on one specific thing, but we've clustered them according to these 4 dimensions: age at death, age of population, crude excess rate, and crude excess proportion. And just to recap, this is clustering so that we can generalize how the age pattern has been affected. So that we can generalize that log scalar that I showed previously. And you can see there's 8 clusters here. What probably stand out is your cluster for, which has Peru, Mexico, and Ecuador. You also have, some overlap in the clusters here. Cluster 4, South Africa, Brazil, Colombia is in there, but you also have a mix. And what this is just saying is that countries that are very similar to these ones on these 4 dimensions, that for those we're going to generalize how their expected and observed age patterns are connected. So as I said previously, really the idea is to generalize that for each cluster, we were able to get a distribution for the log Rx, so a distribution for that scalar. And then we essentially look at all the other countries, and based on their characteristics for age, the age of death, age of population, excess mortality and proportion, we look at the distance, the multivariate distance between a specific country and the average for this cluster. And based on the minimum distance, we basically map every single country to a cluster. Each country will be closer on those 4 dimensions to one specific cluster. And based on that, we basically generalize this log scalar. So there's many different clusters that have been formed. I think I showed you the one just now for Peru and Ecuador. Some clusters have a greater impact on the age structure than others, but effectively we're able to get a distribution of a plausible impact on the age trend and to generalize that. And then what comes out of that process is an entire age pattern. So as an example, what I'm going to show here, again to our familiar countries, Brazil, this is showing if you just took the expected for 2020, the predicted, if we assumed we don't know the age pattern in Brazil, and we just use this method to get the age pattern for the total deaths, that's given in blue with the uncertainty intervals. Then what's in orange there, those are the actual observed deaths for 2020, because for Brazil, we have this. So this is more for an internal validation for Brazil. We're able to, because we have an age structure for it, we're able to do that. And we're able to done the same for all of the countries for which we have data. We were able to look at the difference between the observed and the predicted more as a validation or sanity check. Then for the countries without, we were able to predict an uncertainty interval for them. And this is, so for a country without an age-6 pattern, we'd be using this blue series. For a country that does have, we'll obviously just be using the reported. I think we've already talked about the project plans, the country consultation, so I'm not going to spend any more time on that. Diana covered that quite significantly. But I'll just end off with a summary. So reported COVID gives us an incomplete picture, and we've spoken about why that is, data quality issues, and we know that excess is a more comprehensive, comparable, and objective measure. We know that many countries lack the data to estimate excess directly, so we've generated some statistical models, and we need to use them to estimate excess mortality. With the advice of the TAG, we've developed these approaches, including a method for generating age patterns for excess. I want to emphasize here that we know that limitations abound, right? There'll be questions about how generalizable are the effects that we're estimating to countries without data? How unique or different are the countries without data from the ones that do? And I think these are reasonable limitations, but really what we need to generate estimates for some of these places without data. And this gives us a systematic, defensible approach to doing so, and at least to track global, regional, and country level excess mortality. Empirical data will always be preferred. So our objective from here is to continue working with member states, to continue working with regions, to continue working with research groups so that we can improve the data collection and have more routine data. This is the first pass at this. We're still working with the TAG to improve other methods. The current estimate is up until June of 2021, and then we want to update that up to the whole year for 2021 when we release other estimates in the year 2022. So I think I will stop there and hand over back to you, Patricia. Thank you very much.
Muchas gracias, doctor Mansuburi, por esa presentación tan completa de no solo los retos que tienen que ver con la disponibilidad de los datos, la información, el proceso en sí de estimación, considerando el nivel global, el nivel regional. Sin duda sabemos que implica una serie de estudios, análisis y pruebas, y por eso es que también el proceso de consulta con los países es tan importante. Nuevamente, muchas gracias. Ahora vamos a pasar a la sesión de preguntas y comentarios. Ya tenemos algunos comentarios en la sección específica. Yo las voy a leer en el idioma en el cual fueron originalmente escritos. Y en este caso, primero tenemos uno de nuestra colega Berta de Guatemala, que nos pregunta, y tal vez Diana tú un poco nos podrías orientar, aunque sabemos que siempre hay algunas limitaciones, ¿qué tanto podríamos tener el material que está en el portal, el material que ustedes han hecho disponibles en español, ya que solo está en inglés? No sé si tú podrías comentar algo al respecto.
Sí, buenas tardes a todos, buenos días. Estamos trabajando en las traducciones, la metodología será traducida ya y estará disponible pronto, yo creo que para el final del año probablemente. Este ha sido un esfuerzo de toda la organización para tenerlo, para ir incluyendo los datos como han ido llegando y en escoger el modelo, por eso no hemos tenido aún la metodología en español, pero así que la tengamos lista la vamos a subir al portal y ahí pueden ustedes bajarla y también será entregada a los colegas de paso.
Muchas gracias, Diana. Y esta pregunta también de Berta, yo la pasaría al doctor William Monsubury para que esté atento. Berta menciona qué tan posible sería contar con estimaciones específicas. Sabemos que estamos hablando del exceso de la mortalidad por todas las causas, pero en este caso la pregunta de Berta es con relación a causas específicas, a grupos de CIE, por ejemplo, qué es lo que ha pasado con las defunciones por enfermedades isquémicas o cerebrovasculares o por algún grupo mayor como enfermedades cardiovasculares. Doctor, ¿qué podría comentarnos al respecto? Gracias. Doctor William, si no la puedo repetir nuevamente la pregunta.
Sorry, I don't have the interpretation coming to me, sorry.
I can ask you, because we have discussed this, so they are asking about specific ICD causes. What our team has discussed internally is that we will make available the causes when the global health estimates are released later in 2022. But I think William can provide more details on this.
Yeah, so as you know, right now we have been asking for all cause deaths. So this is total population without looking at specific causes of death. And really, in our next stage, once we start having vital registration data coming in, where the causes of death are certified and recorded in those data, then we're able to start analyzing that. There's a lag of more than a year before we start getting our cause of death and vital registration data. And I think countries would know this in terms of their systems, that it takes time to be able to put these data together. So we have been focused in this first round on excess mortality because it gives us an idea of the full impact without having to look just at the direct or indirect. But that is definitely one of the outcomes that would be in the global health estimates coming up. Cause of death, disaggregated excess mortality. Over.
Gracias, doctor. Luego tenemos una que yo la tomaría como una sugerencia también de una colega, Alan Day, que menciona, this is an interesting tool. Can WHO organize a training for participants to learn how to use this tool for analysis? Diana incluyó una respuesta y dijo que sí se puede proporcionar capacitación. Tenemos otra pregunta también de Berta relacionado con los clusters que presentó el doctor William. Y también preguntan si Bolivia está en algún clúster, al igual que Guatemala.
I will answer the question regarding training. The iLearn training is available for WHO internal use only, but we can share with you through the chat the link to external training for R and signing up as well. Then if you can address the other question in English to William, please, Patricia, so that he's able to respond. Thank you.
Okay. William, you explain about the clusters and you gave the examples, for example, Ecuador, Mexico, and Peru. Have you included Guatemala? Where is Guatemala or Bolivia? People from Bolivia and Guatemala want to know.
Yeah, so we did do the clusters for all countries that have age and sex disaggregated data, and we do have estimates for Bolivia and Guatemala. I'd have to pull them up to see which cluster they're falling into. And then on the question on the tool itself, so with the estimates that we're publishing in December, there'll be an application, a Shiny application or our application or tool that users will be able to, that countries will have access to. So you'll be able to go onto that tool and see what the estimates that are coming out from your country are, and also look at how, you know, different countries look and age and sex disaggregation as well. But in terms of actual trainings, I think we can work with the regions on this. If there's a specific, we've been in contact with the regional office as we started this whole program, and our passion is capacity building. Our passion is to make sure that the countries are strengthened and that they have all the tools they need. So that'll be our passion, and I would be very excited to support that. Thank you.
Thank you. And we also have another question related to how do you work considering that, you know, that some countries use the year of occurrence and other countries use the year of register of death, you know, depending on the national law. So for this analysis, you just use the year of occurrence, but you know that many countries accept that occur in different year, but the registration year. So I don't know if you can elaborate more about this in terms of the year of occurrence and year of register.
That is a great question. We have most of there are some data that are based on date of reporting versus date of death, and we have our aggregates, and in the methodology, we share with the country what data source we've used for our analysis. So one of the country consultation that was mentioned before, the goal of that country consultation is to speak to our focal points from the country and say, okay, this is the data we've used from your country. This is the data source. These are the numbers that we have by month. Are they correct? And if there's any gaps in terms of that, our country consultation is what we've been using to assess, you know, perhaps the country is not using a date of death as the actual number that we need. For our monthly deaths, we have been trying to use we're basing those on the date of death rather than just the date of reporting. And we're assuming that the countries are able to engage in that way. Over.
Thank you. And have you considered the presence of competitive risk when using analysis by group of causes? It's a question from one colleague from Brazil.
Yeah, I mean, when we look at the fact that, you know, one cause might have gone down because COVID. So, for example, someone who would have potentially died from hypertension or diabetes or something else has now died of COVID. We know that there's many changes that have happened epidemiologically. So that's why we're focusing on excess mortality. We know that it covers the direct and the indirect. It covers some of these changes that are happening epidemiologically within the cause of death profile. I think when we start looking at cause by cause analysis, then there'll be more nuanced perspectives that we can look at country-specific epidemiology, looking at the social determinants of health and how that is connected to the estimates. But the goal of looking at excess mortality is to try and get around some of these complications. And in the short term, to be able to track the full impact of the pandemic in a short time space. I think that a lot of countries are asking, people need to know, we need to prioritize vaccination. We need to make sure we prioritize, especially places where the impact is higher than it's been seen. So to be able to get such numbers in a short time, we've looked at the lowest hanging fruit, or the easiest thing we can calculate that covers as much information as possible. So that's why we've used excess mortality. Over.
Thank you. And one colleague from Costa Rica asked about if you tried the difference, what happened if you use, we know that we are using the epidemiological week, but I don't know if you try with ISO week, that is a week start from Monday to Sunday. I don't know if you can talk about this. Thank you.
Yeah, that's true. I think depending on the analytical period and the clustering by time, you could get something. But with the work we've done now, we've looked at monthly estimates. So instead of, we've aggregated everything according to ISO week and then into months, and the numbers are excess death by month rather than by weekend. So we think that, you know, the by month is much less sensitive to the marginals on the week. I think you'd have a few days here and there, the differences between month and how it's clustered, but it shouldn't be very sensitive to your choice of week. Over.
Thank you very much. And I think that this will be the last. About the prediction, for how long could the prediction have a high degree of certainty?
Yeah, the best thing we can do is we're using the statistical uncertainty. So the uncertainty that comes from the Poisson model, and we are looking at the period for which we have variables, covariates for the prediction. So in this case, you will see our estimates are only from January up until June of 2021. So we know that as we keep, you know, the further along we go with that, the wider the uncertainty is going to be. So also there's issues of how good is the reported data if it's only from last week, you know. So we've tried to have a sort of conservative period for analysis that is still going to be informative. But I mean, you saw on the map that I shared, many countries don't have data. So it is a wide uncertainty interval. And you'll see with the estimates that have been shared, the focal points and the estimates that we'll be publishing, and also the estimates on the tool, that there is wide uncertainty intervals for many of the places without data. And that's just a natural result of such an estimation. Over.
Thank you very much. Creo que estas son todas. Solo mencionar que también nuestra colega Diana Esteves mencionó que ellos estaban trabajando sobre el material en español, ¿no? Que sabemos que es importante para contar con todo lo que ellos han incluido en el portal y que próximamente podríamos tenerlo. Nosotros también vamos a estar atentos y por supuesto para nuestros colegas cuyo idioma es español, pues vamos a estar pendientes para también seguir este punto que sin duda es importante. También Diana incluyó en el chat el enlace del portal, porque varios han estado preguntando, y recordemos que los puntos focales designados tienen acceso al portal y al material y nuevamente a la posibilidad de intercambio con nuestros colegas y por supuesto también con la colaboración que nosotros estamos prestos para dar. Pues bueno, hemos llegado prácticamente al final. Agradezco su comprensión porque nos hemos extendido un poco y ahora voy a invitar al doctor Stephen McFeely, que es el director del Departamento de Datos y Análisis de la Organización Mundial de la Salud, para que comparta con nosotros unas palabras. Adelante, doctor.
Thank you. Well, just I think you've heard all the details. You've heard the rationale. So just thanks everybody for dialing in. We just want to say this is a really important process. both in terms of adding context to the COVID story. So like what we really want to do is move beyond the narrow COVID story and show the wider impact. Even though it's a blunt instrument in some ways, it nevertheless adds a lot of important context. And it's really important as well, because this underpins a lot of other statistics. So like these numbers feed into life expectancy, they'll affect the life tables. So this is more than just adding narrative to COVID. It's really going to be important for a lot of the denominators that we use for other statistics. So it's really, really important. So any feedback that you have is most welcome. As my colleagues have explained, what we're publishing in December is the first set of numbers. There'll be further iterations, so there's further opportunities beyond December to improve the model, to incorporate new data. And so this is an ongoing piece of work, because unfortunately COVID is an ongoing pandemic. So with that, I'd just like to thank everybody for your attention, and really thank you for your cooperation and support with this. Thank you.
Muchas gracias, doctor McFeely. Y ahora, antes de ir a la sesión final, solo recordar que un mensaje muy importante que Diana esta vez incluyó en el chat: el acceso al portal es para puntos focales. Para tener ese acceso es importante que los puntos focales designados de cada institución de país envíen un correo al correo que está en el chat, y de hecho nosotros también lo podemos circular nuevamente, y así son reconocidos como puntos focales y pueden tener acceso. Pueden ser más de una persona, y en ese sentido recalcamos este detalle para que puedan ingresar al portal. Y también tenemos dos preguntas más en el chat de una colega de Ecuador, un comentario, y de Paraguay, que lo haremos llegar posteriormente para que sean también respondidos. Y ahora voy a la sesión final, que está a cargo de Adrian Cox, que es la asesora principal en el Departamento de Evidencia e Inteligencia para la Acción en Salud. Y de mi parte, simplemente agradecer a todos, una disculpa nuevamente por el tiempo. Seguimos, y también recuerden que nosotros como oficina regional estamos prestos para todo el proceso, desde aclaraciones, el proceso de consulta, la ratificación como punto focal, así que siempre considérennos y contáctenos. Muchas gracias. Adelante, Adrian.
Gracias, Patricia. Thank you for moderating, and thank you to all of the colleagues from WHO, as well as EIH, and all of the focal points that we have in the countries. I just want to reiterate what everyone said on the importance of the work, and especially that is ongoing. So although there was a deadline for this publication is coming out, with the estimates, it is important to improve the estimate by having as much complete data and information as possible. And the idea of these type of webinars is to make sure you are connected to the right sources, to the people at HealthStat, so it doesn't feel so distant. And whatever questions you have, you can contact us, you can contact the people at HealthStat directly. The idea is that we're not as distant, and we definitely need to reach out and get focal points where countries and territories have not yet identified the focal points. So it is very much ongoing. Do not feel as, you know, the time has passed, you have been left out. We know countries are grappling with the challenges to getting data and verifying the data. So we hope to be helpful in that process. So we thank you. Please contact the WHO colleagues so you can have access to the app, use it. Your feedback is important, and we will continue very, very much this consultation and this technical collaboration with this important topic of excess COVID-19 mortality. So I want to thank you very much for your attention, and we look forward to collaborating, chatting with you in the future on this issue. Thank you very much. All right, the meeting's over.
Thanks, Adrienne.
Thank you.
Goodbye.
You're welcome. Everyone have a
Thank
nice
you
day.
so much, colleagues. Thank you, Adrienne. Thank you, Patricia. Gracias.
Thank you so much.
Thank you.
Thank you,
so
everyone.
much.
It was good to see you, Stephen.
Leave.